Hi, welcome to our short webinar today. I'm here with Erica Badgie, Senior Medical Science Liaison at
Mhm.
MDX Health. She is a registered nurse with a Bachelor of Science in Nursing. She previously was a nurse navigator for a LUGPA and managed the MRI fusion program and active surveillance program. Hi, Erica. It's a pleasure to have you here today.
Hi, Denai. Thanks for having me. Excited.
Absolutely. All right. So today we're going to talk about the advantages of the Genomic Prostate Score assay. So we're just going to kind of go through a few quick questions and talk about the test.
Good.
Today, our first question is why genomic prostate score?
Sure. So, the genomic prostate score has been around for quite some time now, and that's because it's a really solid product and a really great test for patients. And there's several different reasons for that. One of the big things is going to be endpoints really matter. Not all these tests are really designed the same, and not all these tests have the exact same endpoints. And we define adverse pathology really differently than a lot of other products in this space do. And we really feel that our definition of adverse pathology is much more applicable to active surveillance patients and a lot more relevant when we're making those treatment type decisions. And to kind of piggyback on that, not only is our definition of adverse pathology more applicable to active surveillance patients, but the way that we really developed and designed this assay was really to be for these low risk active surveillance patients. And we really wanted to understand which of these patients are going to be, eligible for active surveillance and which really need that active form of treatment to where we can intervene sooner and save these men's lives. On top of that, long-term data follow-up is really, really important when we're talking about putting patients on active surveillance or moving them on for treatment. And we're going to have some of the longest term data out there in this space. And then on top of that, just patient access, whether that be billing and financial or tissue requirements. The way that we designed that assay, knowing we were going for those active surveillance type patients, we knew we were going to be dealing with biopsy samples. So we wanted to make sure we were going to be able to give reports out at extremely low levels of cancer. Some of these guys have one core of Gleason 6, 5% involvement, but there's still a chance that we missed adverse pathology. So we want to be able to service those patients as well. So great endpoints and a more holistic approach and a little bit more wider spread accessibility for these types of patients.
Absolutely. And can you tell me which genomic tests were developed specifically for active surveillance?
Absolutely. So if we kind of, rewind back to 10 years ago when these products really started hitting the market, genomic prostate score, or what we call GPS, was formerly known as Oncotype DX. And when I was in practice, actually, that was the only test for active surveillance patients. It was really designed for Gleason 6, Gleason 3, 4 patients, and Decipher and Polaris didn't even compete. They were designed for these higher risk patients, these unfavorable intermediate risk, these high risk patients. And even further, they were designed to be post radical prostatectomy tests. And so they've kind of backed into this space a little bit, whereas we were always focused in this space. This is how we designed our algorithms. This is how we designed and picked our genes in our assay, was to really identify and address those active surveillance eligible type patients. That's why our definition of adverse pathology is going to be that primary pattern 4 or that T3A, that non-organ confined disease. We're not waiting for seminal vesicle involvement like Decipher is. We know that, the difference between T3A disease can really be, localized advanced disease versus T3B, where we're looking at micrometastatic disease, and that's a very different ballgame. So more applicable adverse pathology definition, 20-year follow-up data on our AP mets and death risks. And again, those genes that we selected were based upon biopsy samples. And when we're talking about active surveillance patients, we don't have a prostatectomy to make those decisions for, right? So we've got to really make these decisions based upon biopsy samples. And that, again, kind of what I said earlier with the design of the assay, that's why we require so much less RNA, that 5 nanograms, because when we designed, we were dealing with these small volume samples as opposed to the competitors that actually use 5 times the amount of RNA, and makes it a lot less likely that you're going to get reports for patients at smaller sample sizes. So that's really one of the big selling points, or the differences between GPS and some of the people in this space.
Absolutely. And which genomic tests predict PT3A, extra prostatic extension at radical prostatectomy for lower risk patients? I know you touched on a little bit in the previous slide, but tell us a little bit more.
Yeah, absolutely. So I kind of did just touch on that. We're going to be the only test in this space that actually really looks at that T3A disease. And why is that important? Kind of just what I just said. It's really the difference between locally advanced disease that we can still get a cure rate on this patient between that T3B. We're talking seminal vesicle involvement. We're clearly moving outside the gland. And a lot of the times, a lot of the literature shows that's really associated with that micrometastatic disease. And so now we're looking more at systemic disease, right? So we all know prostate cancer is extremely curable if we find it contained within the prostate. So when we're talking active surveillance, any patient that's going to have primary pattern 4 disease or any disease that's breaching the capsule is really, really important and really important to intervene as soon as possible on. And that's why we feel our definition of adverse pathology and having T3A as an endpoint is super, super important and can really impact the outcomes for these patients. And a lot of our data shows that.
Absolutely. And which genomic tests have 20-year follow-up data for clinically relevant endpoints?
So that's going to be us, right? The genomic prostate score. We're going to be the only test in this space to have that 20-year outcomes data, which is really substantial. It's a significant amount of time for these patients. It assesses whether or not our definition of adverse pathology is still important at 20 years, and we absolutely showed that it was. It also showed that that GPS score is still correlated with distant metastases and prostate cancer specific mortality at 20 years. And so this is a significant timeline for these patients. So again, having long-term outcomes to really understand, are these endpoints relevant and still meaningful? 20 years, patients are living a lot longer nowadays. And so having the longevity to these types of results is really, really important, something that really separates us from the other tests in this space.
Absolutely.
Exactly. This is exactly what I referred to. Again, having that GPS association with that distant metastases, that prostate cancer specific mortality, we start to see a nice market increase as that GPS score starts to go up. And then on the right side of the screen, you actually see we actually add to the area under the curve, meaning we're going to make ourselves a little bit more accurate by adding the GPS score. So not only is it associated, but it's also going to improve the standard of care for these types of patients.
Yeah. All right, Erica, thank you so much for your time today. I appreciate you walking through those key questions about the advantages of GPS. If anybody has any questions or would like to speak with Erica, please let us know. You can send us an email at info@mdxhealth.com. And I hope everyone has a great day. Thank you, Erica.
Thank you.